Oh my goodness. I'm starting to see how this would cause pain with intercourse now. Tighten up. You don't have the straight shot. Things are kinked and bent.
Yep. And the muscle's tender. So that this muscle winds up getting inflamed and it winds up getting tender. So even touching that muscle can wind up being painful.
Hello. Welcome to the Dr. Gill Show. My guest today is my friend and return guest, Dr. Brett Barrier. Welcome back to the show, Brett.
Thank you, Gil. Appreciate it.
Brett is an associate professor of OBGYN at a large Midwestern university. You've been a graduate past a residency, a true doctor for over 25 years. And you have incredible expertise and experience in the general field of obstetrics and gynecology. And our last chat was about prenatal care, and we talked about a lot of issues surrounding pregnancies and whatnot. Today, we're going to talk about a very different topic. We're going to talk about painful intercourse in women, and how do we treat this, and how do we improve this? It's a big topic, and it's important. Intercourse should be enjoyable. It should be fun. It should be procreative, meaning you can have babies. And apparently, there is a huge population crash coming around the world. So we need to do our part to keep the population going. That's a whole nother topic. Now, just a little warning point here. If you're squeamish, we're going to be talking about female anatomy graphically. We're going to be talking about every part. We're going to be talking about urination, defecation, intercourse, sexually transmitted diseases, all these things. So if you want to learn about these things, here you go. If you're a little squeamish, go to our next video. Okay, so we're going to be talking. We're both physicians. This is a medically oriented podcast. So we're going to delve deep into medical matters. So, treating painful intercourse. I think the first place to start, Brett, would be basic female anatomy. I was going to bring some models and stuff, but I think we can just talk about it here. A common misconception is the external female genitals are the vagina, right? Wrong, right? The external genitals are generally called the vulva, but then you've got the perineum between the vulva and the anus, and you've got your bottom there. The vulva's got numerous parts, but for here, you got to just, for this topic, you need to understand that the vulva is just a skin and dermatologic or skin issues that can happen anywhere on the body can also occur on the vulva. The opening going into the vagina is called the vestibule, and the vestibule has glands that come into it, and pretty much the top of the vestibule is the hymeneal ring. Hymeneal ring is a tight spot and it's very variable. Some women barely have any. Some women can have a membrane or almost a wall that covers the entire opening of the vagina. The vagina then goes up beyond the hymeneal ring to the vagina proper and what's called the vaginal vault. On the top of the vagina is the opening of the uterus called the cervix. The cervix is the neck of the uterus. That's where it gets its name. Then you have uterus, and connected to the uterus, you have the tubes and the ovaries. In front of all this is the bladder and the urethra, very, very tightly interconnected. Behind this, or posteriorly, is the rectum and the bowel. So these are all intimately connected, and the disease of one can cause pain in the other. Am I right so far, Brett?
Mm-hmm. Sure.
All right. So a lot of things can go wrong here. And so when a patient tells you, Dr. Barrier, she's in the office, says, I'm having painful intercourse. How do you start the evaluation since so many things can cause painful intercourse? Where do you start, Brett?
Usually I want to know what the setting is for the intercourse, for the pain. How often is it happening? Is it every time? Is it happening around the time of a period? Is it happening throughout the cycle? Is it happening every time someone has intercourse? I'd like to know the character of the pain. Is it with penetration initially and then goes away? Is it something that's not there at first and then starts developing? I'd like to know, does it feel like it's towards the outside? Does it feel like it's way up inside? Is it referring some other places? Is it referring up to the abdomen, one side or the other of the abdomen? Is it referring to the rectum? Is it causing back pain? So there are a lot of different ways of describing pain as well. So is it a burning pain? Is it a stabbing pain? Is it a kind of a just an annoying crampy pain? And so all of those will give clues as to the source of the pain.
Okay, what you're saying is what you can infer from this, Brett, is it takes some time. This is called a history, and you need time to elicit a history. I see women, although I'm a fertility doctor, this certainly comes up. And too often I hear from a woman, I said I had painful sex, and the doctor spends 10 seconds on it and has not done a proper evaluation to determine what type of pain is it, So in general terms, I will summarize this. You have pain on the outside, generally called insertional dyspareunia, when you're getting, and we're talking about standard, traditional penile vaginal intercourse here. Okay. We're talking about, there's pain on the outside, generally with penetration, and then there's pain deep on the inside of the pelvis. Okay, very good. So there's different locations. That's a first clue. Something that folks may not realize is that a woman's anatomy is not always the same, and there are abnormalities of the formation of the uterus and the upper vagina, which can go all the way down, called Mullerian anomalies that are actually quite common. I occasionally see a woman with 2 vaginas, and people go, 2 vaginas? How could that be, and how could that be missed? Well, that comes down to what I started with. The vulva is not the vagina. So these women have a normal vulva from the outside. When this girl was born, she had a normal vulva. When she was a teenager, she had a normal vulva. But lo and behold, she has 2 vaginas. And frequently this is missed. She goes for her first pap test. They look inside. They see a vagina. They see a cervix. They do the pap test. Nobody bats an eye. Because they're not looking for going the other way and finding yet another one, right? It's rare enough it doesn't come up.
Or it's closed off.
Or it's closed off, correct. And then you can be missing a kidney on this side. Oh, it gets interesting. It gets complicated. But instead of a normal barrel, normal vagina, you can have 2. And there's this septum thing here. And sometimes it's been... women will have painful intercourse, but generally one side stretches more than the other, and they're having intercourse on one side. The pain may or may not come. Anyway, so you can be born with abnormalities, and you need to examine the patient with the open-mindedness to see what's there, not what do you preconceive. You can also have tightness of the hymen. Now, in a normal woman with intercourse over time, the hymen stretches, and it's no big deal. But you can have constriction and abnormalities of the hymen, can't you?
Yeah, and they're different. Usually these will show up earlier with initial intercourse or with painful periods. That sometimes the hymen can be completely intact. It can be no space at all for blood to come out.
No space at all.
And so you can wind up with blood that just pools in the vagina. And when someone is having painful periods and really not having bleeding, you can't even tell that someone's having periods. This is what you'll see as a reproductive endocrinologist. Yeah. Someone will come in with an imperforate. We call it an imperforate hymen.
Imperforate, that's the name. And it can be bulging purple thing sticking out. Obviously can't have normal intercourse in that circumstance, and it's painful. So attention to the hymen and how that contributes, very, very important. Women can also experience injury in childbirth, can't they?
Yeah, that's relatively common. I think 7% of deliveries vaginal deliveries can result in an injury to the anal sphincter complex. We call those oasis injuries, obstetrical injury of the anal sphincter. And so the oasis injuries can result in pain with intercourse later on, and also some dysfunction in bowel function, and sometimes in urinary dysfunction.
Yeah. So when the perineum gets frequently injured in a vaginal delivery, frequently there's tears or an episiotomy. These things can heal with scarring, granulomas, nerve issues, and whatnot. So if a woman's had a baby, attention to the vulva and perineum is very important because there can be a lingering injury there causing painful intercourse.
Yeah, I mean, usually those are temporally or time connected with the delivery event. They didn't have intercourse beforehand. Now they're having, they didn't have pain beforehand. Now they're having pain afterwards. And they can point to the spot that's causing pain, which is usually where that tear or that repair is.
Occurred. Okay, so just take some focus there. Now, we're talking about insertional dyspareunia. The most common cause of that is dryness. And once you get real graphic, sometimes people are going too quickly, and foreplay or timing or romance and whatnot is important to give the woman time to establish normal lubrication. Is this true?
I think definitely dryness is a common cause of painful intercourse, and it can be due to the things that you mentioned. Just someone's not ready for intercourse or maybe interested in intercourse, and so it becomes uncomfortable. Some things as simple as a yeast infection can cause a sensation of dryness, and then that can result in discomfort. That's usually not something that's happening over months. It's more like weeks that someone notices that. Age is a factor. If someone goes through the menopause, the estrogen levels drop, and the glands that naturally provide that lubrication can kind of turn off. We call them, they become quiescent. And then you can wind up with dryness. It's just simply related to lack of estrogen.
Okay, also when you get near the menopause. And also, sometimes it's a clue. What I see in my practice is women going through premature menopause. And you have a otherwise healthy 20-year-old woman, and it hurts, and lo and behold, she's run out of eggs, hence is running out of estrogen, and things are getting atrophied and whatnot. So that needs to be evaluated as well. And you also bring up irritation or vaginitis. Like I tell my students and my nurses, vaginitis is not a sexy topic. Nobody wants to talk about it. But if you have it, it's really important. And it's a source of chronic pain and misery in some women. And if it happens to you, it's a big deal. And that also is kind of a tricky thing to diagnose. Also takes time, takes attention. But let's just say in general, vaginitis can also cause pain with intercourse. I warned people I was going to get graphic here. Some women get a yeast infection, and the vulva is just cherry red. You look at it, it looks hot. It just looks painful. It must be miserable to have a really bad yeast infection. So it's not just an annoying little thing. It's a big, painful deal, isn't it?
Especially in patients that have diabetes.
Ooh.
The yeast that causes, it's usually Candida, and it's usually Candida albicans that causes the infection, but we call it a dimorphic yeast. So there are different forms. There's a yeast form where it's round and it just buds off like yeast. And then there is a fungal form or a hyphal form where those yeast will start forming long tubular structures, and then they can branch. And whenever there's a lot of sugar around, the yeast form takes advantage of that energy, and it stays yeast. If there's not a lot of sugar around, then it'll form these hyphal structures. The hyphal structures, these long tubular structures, they grab onto epithelial cells, and so they form these clumps that look like cottage cheese.
Yes.
But if someone has diabetes and it's just the yeast forms, it typically doesn't form those clumps. And the vulva gets very red, and it looks very fiery, and it can be very, very irritating.
Very irritating, very painful. And these forms you're talking about, this is what we see under the microscope. And it takes time. It takes time to do a proper microscopic examination. So beyond routine more common vaginitis, there are sexually transmitted diseases that can also cause painful intercourse, aren't there?
Yeah, there are.
Yes. Now, I think the granddaddy of them all, the most painful, is gonorrhea. Is that true?
Yes, gonorrhea, although it's a little more rare than the others, it causes the cervix to be extremely sensitive. So you can just barely touch the cervix, and it causes a lot of pain.
We call that cervical motion tenderness, CMT.
Mm-hmm.
And so gonorrhea can clearly cause pain. Chlamydia, the more common one, sometimes a woman will barely know she has it, right?
That's one of the problems with chlamydia, because it can stick around for a long time without being treated because it doesn't really have a tell with symptoms. And then, unfortunately, it also can lead to infertility if it's there for a long time, because that chronic infection can scar the tubes.
Damage the tubes. You can get some pain with chlamydia, and it can go up into the sides of the pelvis as well. Now, there's also another disease. I saw a lot of this when I was a resident. I think we see less of it nowadays. There's something called trichomonas.
Yeah, trichomonas is still pretty common in general practice. It's causes pretty severe irritation, kind of just a burning with intercourse, and it causes a discharge that has an odor that's characteristic. It doesn't usually go untreated, because when someone has it, they know they have it pretty quickly.
There's something there. And I used to say in bad cases of trichomonas, I can make the diagnosis opening the door to the room, walk in, and it's characteristic. Once you smell it, you never forget it. So infections can also cause painful intercourse. Clearly need to treat those. Now, there's a somewhat mysterious condition called vaginismus that can cause very painful intercourse, and sometimes can make intercourse virtually impossible. What is vaginismus, Brett?
Yeah, so vaginismus is diagnosed when the opening to the vagina is extremely small. And so essentially it's someone that has vaginismus really can't place tampons. They can attempt intercourse, but not even really be able to have intercourse because of the inability to penetrate.
Now, is this a kind of just a reflex clenching or tightening?
So this is due to a muscle called the Puborectalis muscle.
And we're going to get to that in a little bit.
Yeah, but there's it's a muscle spasm that causes that opening to clench down.
Yeah. Now, is that sometimes related to previous traumas or something, or psychological issues or fear or anything, or is it more complicated than that?
It's much more complicated than that. Those things definitely can be contributors to it, but that's not really the biological cause of it.
Okay, and that's a whole nother world of treatment. I just seem to remember it involves using dilators. You start with something really small and just get bigger and bigger over time with counseling. And
yeah, we'll get to that a little bit later.
Yeah.
Because there's a better way to treat it. Yeah.
Oh, I want to hear about this. Now, just one more to talk about vulva. One more, let's just focus back on that. The vulva can have all kinds of skin conditions. They're called
vulvar dystrophies.
Vulvar dystrophies. Thank you very much. And they can be difficult to diagnose, but with proper attention, they can be treated. And I think almost all of them are treated with topical steroid creams. Clobazole is your friend. I was taught that. Now, there's also something called Vulvodynia, a pain of the vulva, just touching it. That's always been rather mysterious to me, and I think mysterious to everybody. Can you just briefly touch on vulvodynia?
Yeah. So the thing you need to know about it is it's mysterious.
Okay.
Yeah, so there are a lot of theories about it. Everything from autoimmune, inflammatory, to a neurologic condition where sensory nerves overact, or inhibitory nerves that prevent the sensory nerves are not acting like they should. So it's definitely a pain syndrome. The way it's diagnosed is everything else is ruled out.
Okay.
And the vulva skin usually looks normal. but just touching it with even a Q-tip can cause significant pain.
Significant pain, just mysterious. And I know in the old days they used to do all kinds of injections of, was it gentian violet or whatever that kills the nerves, essentially numbing the vulva. So it was one of the treatments.
Yeah, there's people will try topical pain medication like gabapentin. Sometimes it's assumed to be due to a contact dermatitis, and so something as simple as coating the vulva in Crisco, which is just
something, an oily base
that'll prevent allergens from getting on the skin can be helpful. Sometimes going as radical, and it's not a big surgery, but to remove the skin that is sensitive. It's usually localized. And if that area of skin is removed surgically, that's the last resort, that is usually pretty successful in treating it.
Interesting. Boy, this is complicated. Now, moving from external pain with penetration, more mid-pelvis, there's now the deep pelvic pain. And that can happen immediately, or there can be cramping and pain after intercourse and whatnot. And in my world, because it's associated with infertility as well, it's frequently associated with a disease called endometriosis. Now, people have come up with various tests, biopsies, blood tests. I even heard just recently of someone working on a company working on a saliva test, looking at messenger RNAs to see if you can diagnose it that way without having to do surgery. But when do you start considering endometriosis, Brett, as a cause of pelvic pain, particularly deep pelvic pain?
Yeah, that's a good question. So endometriosis is, with the pain associated with endometriosis is usually, as you mentioned, deep. It's not an entrance penetration type pain. The pain often will settle on one side or the other. It is associated with painful periods. So typically somebody who is not having painful periods, it would be a little unusual to have endometriosis as the cause of pain without having what we call dysmenorrhea or painful periods. Endometriosis can cause a lot of scarring up inside of the pelvis, which can scar the ovary against the uterus, or the ovary can be involved in endometriosis.
So they're stuck. I like to say things should be slippy slidey in there. When things are stuck, it's going to cause pain throughout the pelvis.
Yep. And also the ligaments, we call them the uterosacral ligaments that go from the cervix to the pelvis. Those ligaments can get endometriosis in them, and that causes the ligaments to scar down, and they become stuck. Yeah. And the endometriosis itself, the lesions can cause pain. And so intercourse is going to affect all those structures, whether it's the ovary or the uterosacral ligaments. It'll affect all of that and cause pain.
It's a big deal. And I like to stress that it really requires a very careful, thorough pelvic exam if you can. Ultrasound adds some value because sometimes you can see endometriosis invading the ovaries. MRIs do have a role for what's called deeply infiltrating endometriosis. But I found in my practice, they properly done, careful, slow, not rushed pelvic examination can find these lesions, particularly on these uterosacral ligaments. We feel them, if they're hard, painful, contracted, the chance of endometriosis is at least 80%, if not 90% in these situations. So I have another video on endometriosis with Pat Young, a wonderful surgeon in St. Louis, and I would encourage folks, if they want to learn more about endometriosis, go to that podcast on endometriosis. Now, I admit...
I'm sorry, I'm going to...
Sure. No problem.
Looking for a break.
Sure. That's a good one.
Let me blow real quick. And just
have a good one.
Sorry, it's these... The harvest right now is just, every year it gets me. I don't know if it's the soybeans or the corn.
It's something. Okay. Now, Brett, there is an area of pelvic pain in which you have tremendous expertise. It's a type of pelvic pain that you've been treating for many years. And I believe the acronym for it is TRAP, Tonic Reflex Activation of the Puborectalis. And I think, did Dr. Foster retire?
No. Dr. Foster's very, very active.
There is he is technically a urogynecologist. There's a wonderful urogynecologist, a Dr. Foster, that is very knowledgeable, and he's contributed a lot to this area of pelvic pain and pelvic function. And before I get into the puborectalis, let's just talk about the pelvic floor for a second so everyone understands what it is. It turns out guys have a pelvic floor too, and it's the same muscles. And if the pubic bone is above, it's a sheet of muscles, and you can divide it into 3 different sections if you want. But basically, it's a bowl, and these are the muscles you contract. For example, when you're trying to hold in your urine, if you're trying not to pee, and in guys it's the same thing, gals it's the same. That is a contraction of the pelvic floor, pinches the urethra, holds the urine in. Now there's another sling that goes. There's essentially in women there's 3 essentially penetrations through this pelvic floor. There's the urethra for the urine, there's the vagina for all it does, and then there's the rectum, which goes through this as well. And when you contract these muscles, it kind of pulls everything up. Helps you hold in your stool, tighten the vagina and whatnot. And the generic exercise for women, I think it's called Kegels. Would that be a Kegel exercise? Would be for strengthening the pelvic floor?
Mm-hmm. Yes, Kegel exercise it's focused on causing those muscles to contract, and exercising those muscles will cause them to be stronger.
So you can exercise these muscles just like any other muscle in your body, voluntary muscle, somewhat. Now, is it completely voluntary, or is there an involuntary component to it?
Yeah, so it depends on which layer you're talking about. So the top layer are the levator muscles, and that forms the sheet that goes across everything. Whenever you cough, for example, there's a whole bunch of pressure placed down into the pelvis, and those levator muscles will, as a reflex, lift up and give counter pressure to the cough. So in patients that have weakness of the levator muscles, they are prone to a condition we call pelvic organ prolapse, where the bladder can drop or other things can drop, the uterus can drop through those muscles. And then the second layer of muscle is really the puborectal muscle. It's the one, muscle that's most involved in continence, fecal incontinence, probably urinary incontinence to some level. And that layer, that muscle is both voluntary and involuntary. It has signals that go to it that you can control, and then it has signals that go to it that are beyond our control. The puborectal muscle is the one that's involved in sexual pain for the most part.
So now that we've talked about the other causes of pain with intercourse, let's say we've ruled them out. No lesions, blah, blah, blah. We've all the things we've talked about. What makes you start keying in on the possibility that this puborectalis muscle is tight and painful? How do you go in that direction?
Yeah. Well, I think the best way to approach it. Let me just describe the symptoms that it causes. I think that's the best way to start. So if someone comes in and tells me that they're having sexual pain, and it's pain, it could be entrance, it could be deep. These muscles are right on the border between the two. So really any symptom can be a tell for pain that's due to what we call myofascial pain, or this puborectal muscle causing pain. So because the muscle squeezes and helps with continence, this affects both all of the vagina, the rectum, and the urethra.
And continence means being able to hold in your urine, hold in your feces until you're ready.
Yeah.
When you're incontinent, you can't do that as well.
So if someone comes in and tells me that they have frequent urination, difficulty getting started with urination, they're maybe unable to empty their bladder completely. They're right back in the bathroom afterwards. And this is a problem that happens most of the time for them. And then they also tell me that they have bowel symptoms. Typically, they'll say they have IBS, irritable bowel syndrome. But they'll have painful bowel movements, difficulty getting started with bowel movements, difficulty finishing bowel movements, wiping for a long period of time. And then they tell me they also have the sexual pain, that triad of what we call urinary dysfunction, defecatory dysfunction, and sexual pain. To me, I mean, it is pelvic floor dysfunction causing the pain until proven otherwise.
So that's to tell. When you have that triad of symptoms, boom, that's a very likely diagnosis to be considered.
Yep. And the reason is that the dysfunction of this puborectal muscle is what causes all those things. So as you mentioned before, you have the rectum, the vagina, and the urethra going down through the pelvis.
Okay.
The puborectal muscle forms a sling that pushes all three of those against the pubic bone.
Okay.
So the muscle starts at the pubic bone, connects to itself, and the other half of the muscle goes back to the pubic bone. So when these muscles contract, they contract against the pubic bone, and it pinches everything forward. So when someone, and we're going to get graphic about
Let's do it.
defecation, but when someone is having a bowel movement, that muscle relaxes if everything's healthy, and it allows a straight shot for a bowel movement to happen. But when that muscle is contracted and it's staying contracted, that's the dysfunction.
Yeah.
Then it's almost like you're pooping over a hill.
Right.
And so it causes straining to have a bowel movement.
And sometimes you can have thin or pencil stools or things like that because it's not, like you said, a straight shot with normal caliber.
Right. Yeah. So and not only is it pinching the bowel, but it's pinching the urethra that you're peeing out of.
Okay.
And so it will cause someone to have urinary retention and stool retention. But the reason that this muscle does that has to do, it's a normal mechanism that it's a reflex that helps us to remain continent of stool. It helps us to not have a bowel movement when we don't want to.
Right.
So in a healthy pelvis, this muscle relaxes and contracts in a way that is proper functioning. So let's say it's relaxed, someone's going shopping, and then the food that they had turns into waste, and that waste drops down into the rectum.
Okay.
That causes a reflex that makes this muscle contract.
Okay, it's like breathing. You don't have to think about it. It's going to happen.
It just happens. And then when someone feels the urge to go, they go to the bathroom. And when someone sits on the toilet to have a bowel movement, this is a little bit of a train response, but that reflex is inhibited. That muscle relaxes, and then it's easy to have a bowel movement.
Okay.
Okay, so that's the normal mechanism. If stool drops down into the rectum and someone does not go to the bathroom right away, that urge goes away. And unlike the bladder, you can't hold your bladder too long. You're going to wind up stopping on the side of the road and peeing. But with the bowel, there's liters of capacity for that stool to accumulate.
That's right.
And so someone can decide, well, I'm not going to go now. And then but as long as that stool sits down in there, this muscle is going to stay contracted. The reflex has nothing to do with what we're thinking. It's a reflex. And so that muscle will stay contracted. And for people that are in the habit, and it's usually from childhood, I found, of just not using the bathroom very often, this process will snowball. The stool will become hard. It becomes painful to have a bowel movement. It makes it less likely for someone to want to have a bowel movement, and it winds up accumulating. And that stool stays there for long periods of time. It gets hard because the longer that stool's in the rectum, the more, or the bowel, the more water's drawn out of it.
Right. The large bowel pulls water out of things.
And so that stool will stay in there. But the whole time it's in there, it's causing this puborectal muscle to contract down, and it becomes like Arnold Schwarzenegger. It's burly. Instead of being the size of a pinky, it winds up being the size of a thumb or bigger.
And you can see this.
You can see this, and this is what causes that vaginismus. So that process where the vagina is completely constructed.
The muscle gets too strong. Gets hypertrophied, I think is the name.
It becomes hypertrophied, and it winds up just staying like that. Then over time, because 25% of the muscle fibers, more or less, are voluntary muscle fibers, those voluntary skeletal muscle fibers, they don't like being contracted all the time. The other types of muscle fibers, the type 1 muscle, they're okay with it, but the voluntary muscles don't like it, the type 2 fibers. So they wind up developing trigger points, and trigger points cause this muscle to start spasming, and then it kind of keeps that muscle in a locked position. So someone can walk around with it locked like that for quite a while.
Oh my goodness. I'm starting to see how this would cause pain with intercourse now. Tighten up. You don't have the straight shot. Things are kinked and bent.
Yep. And the muscle's tender. So that this muscle winds up getting inflamed and it winds up getting tender. So even touching that muscle can wind up being painful. And so also a bowel movement can be painful. And also sometimes in some patients, urinating can be painful. But the pain always goes to the same spot. It's usually going to be somewhere in the lower abdomen.
Okay.
I'd say most of the time, 70% of the time, it's in the left side. I don't understand why, but it's usually left-sided. Huh. It's right at the pelvic brim. But whether it's pain with intercourse, whether it's defecation pain, whether it's urinary pain, whether it's just chronic pain where someone's walking around and sitting for a long time or riding a bike, it can cause this pain. That's where the pelvic floor often will throw its pain, is right here on especially the left side. Although it can be all the way across, or sometimes it's on the right, but it tends to go towards the left.
Wow. So you've got the history, we've got the story behind this pain. Is there anything particularly on an exam or a pelvic exam that a doctor would find that would further suggest this diagnosis?
Mm-hmm. Yes. So the exam is. I diagnose this mainly based on history. If someone has defecatory dysfunction, urinary dysfunction, and pain with intercourse, then I will piece that together. And the defecatory and the urinary dysfunction, so the bowel problems and the bladder problems, relate to obstruction. So you just can't empty them. And so when someone has symptoms like that, I'm already thinking she probably has pelvic floor dysfunction. Mm-hmm. And it's really common, very common. I'd say 10% of the patient population is walking around with this.
Really?
Yeah. And so, but on exam, that is the way of, in my mind, proving that it's pelvic floor dysfunction, because if I do an exam and it's called palpating, but if I push on that muscle, it is very tense. It's very tender. Sometimes the vaginal opening is constricted, especially if someone hasn't had kids yet, or hadn't had a vaginal delivery before. And so when I push on that muscle, it will often, if someone's having that left lower quadrant pain, the pain in the abdomen, mm-hmm. pushing down below, just inside the vagina, can cause that pain up here. And so for me, that's proof that this muscle is what's causing that pain. Yeah.
So finding an experienced clinician that's done this thousands of times is so crucial, because a medical student, somebody who's less trained than you, is not going to be able to make that association or make the specific finding.
I mean, it's relatively easy to produce that pain. The problem is that most people that are evaluating pain that aren't looking for this will go in and do a bimanual exam.
You just go straight in, dive in, and right. They've missed all the subtleties.
And all the you can have abdominal wall pain, you can have bladder pain, you can have bowel pain, you can have endometriosis, you could have pelvic floor. And so this type of an exam to look for pain is going to trigger pain.
It's going to hurt.
And now we don't know where it's from. So the exam has to be point by point, level by level, trying to evaluate where is that source of pain.
Crucial. That is a pearl, Brett, that really needs to be appreciated. Very important. So we have a woman, she's got the triad, she has the symptoms, her pelvic exam strongly suggests this. How do you treat this?
So it's actually very simple. Okay.
I say, it's simple but not easy.
It's not easy. Yeah, it's very simple, but it's not easy. And the problem is that this is all on the patient. So there's not a surgery, there's not a medicine, there's not a pill. Pelvic floor therapy is helpful if it's persistent. Like if we've tried some other things and we're not better, you can sit pelvic floor therapy. The pelvic floor therapist can go in and help someone relax these muscles. There are different ways of doing that, but the treatment, I consider the first line treatment, get rid of the reflex. It's a reflex from chronic stool that's causing this muscle to contract and to stay contracted. So what you need to do to fix it is pretty simple. You have to empty out the bowel.
Empty the bowel.
And keep it empty. And then that reflex goes away. And it takes a while. It takes 1 or 2 or even 2.5 to 3 months of keeping the rectum empty. Of emptying. But that muscle no longer gets that reflex. And almost like someone who's been playing college football and they're 240 pounds,
right?
As soon as they get a desk job, right, they're dropping way down, right?
Yeah,
the muscle goes away.
Right.
So this muscle will wind up going back to normal, and it will start functioning normally. And it's amazing, over 15 years of treating this, the vast majority of patients that just make these changes with diet, emptying the colon completely, and then going on a soluble fiber is what is required.
Now, you have a favorite fiber, I think. What type is that?
Psyllium.
Psyllium. What is that? Is that Metamucil?
Metamucil is a brand.
Is a brand. Okay.
Yeah, there's Reguloid and
I have
others.
no financial interest with them, but they have TV commercials.
Right.
All right, I see the name. Okay.
Yeah. So psyllium is a seed husk. It's like a chia seed. And most people are familiar with chia. You add water to it, and it blows out. So psyllium does the same thing, but it's a seed that gets ground up into a fine powder, and when water is added to it, it turns into a gel. And in fact, if you mentioned Metamucil, if you take a scoop of Metamucil fiber and place it in a glass and add water and then drink it like an orange juice, that's what the container says. It'll be fine the first couple sips, but it'll get thicker and thicker as it sits there until you're trying to drink a glass of Jell-O is what it's like.
Okay.
So a lot of people don't like the Metamucil because of that. But what that Jell-O type gel substance does is it holds onto water and it does not get digested. So the stool stays soft. It also has a slipperiness to it that stays with that stool, and it has to have water for this to work. But it causes the stool to remain slippery. So then when it gets to the end and it's having to go over that hill, it's easy to slip over the hill. So it allows someone to keep evacuating completely, which will allow the reflex to get better. But there are other types of soluble fiber that do this. So oatmeal, that sliminess of oatmeal.
Oh, yeah.
Oatmeal is another easily accessible soluble fiber. Prune juice, that's pretty well known.
How does prune juice work?
Same thing. The plums, which is what prunes are, grab onto water and hold onto that water, and there's parts of the plum that doesn't get digested, so that water stays with it.
I always wondered because it seemed like a liquid to me. Okay.
Yeah. So, but so the first step is emptying out, and the second step is starting the soluble fiber. If the steps are reversed, if I was to drink that thing of Metamucil, but my colon has a whole bunch of stool in it, that gel will go down and then it'll stop and it'll bloat.
Oh, that sounds terrible.
So the most common symptom with fiber, if someone has not first emptied out the colon, is a significant amount of bloating that'll stop people from using the fiber.
Yeah, it's going to hurt. Now, if the fiber doesn't work, can you get a little more aggressive with something called Miralax?
Well, that's what you should do first. So the first step is to empty out the colon.
And Miralax works the best, maybe?
I wouldn't say that.
Help me.
A large amount of Miralax probably would work pretty well, but in the doses, it's more of a gentle laxative. For the nuclear blast, I would recommend a bottle of magnesium citrate.
That's what we use preoperatively on
magnesium
our patients.
Citrate. And then it's important to drink even another, drink that whole bottle and then a whole nother bottle of water behind it.
Chase it.
Because what this does is that magnesium stays inside the intestine and it draws water in, or it holds water in, and then it flushes the colon. So it's a flush. That's what all of the powder laxatives and liquid laxatives, they will stay in the intestine and flush everything out.
Okay.
And then if you really want to hit a home run, as soon as everything's really gurgling, take a pill laxative like a Ducalax, which causes the intestine to cramp down, and then it'll give a final push to push everything out.
So we need a full evacuation then maintenance.
And then maintenance is with this fiber. For the Metamucil fiber, I would not recommend drinking it like a drink, because you have to drink it too quick. what I would recommend is taking in Colombia, we're familiar with Shakespeare's pizza. So if you think of a Shakespeare's cup, big round bottom and about that tall, if you put a tablespoon of that psyllium in a Shakespeare's cup and just enough water to make a slurry, you can throw that down like a shot.
Okay.
And then immediately chase it with 2 cups of water. Yeah, or a full Shakespeare's
drinking all
cup.
that jello-y, slimy stuff.
Right. Yeah, but it has to be it has to mix in the stomach. So if you take the psyllium first and then wait, or if you take the psyllium gummies and then wait and drink water later, the water won't get to the psyllium, and it'll have the opposite effect.
And it'll be a plug.
It'll be constipating.
That's why people talk about this plugging. And after 2 or 3 months of that, frequently this trap syndrome improves tremendously.
I would say the majority of patients, it goes away.
Wow.
It's completely back to normal. And I've noticed this. So for 15 years before Dr. Foster actually is the one that said, I don't think it's endometriosis causing a lot of pain in these patients. I think it's the pelvic floor. And at the time, I had an endometriosis pain practice with a lot of referral for chronic pain. I was managing patients that I had done surgery on, other people had done surgery on. They weren't getting better, and I didn't have a good explanation for it. And so they were using alternative, medicine, acupuncture, things like that. And Dr. Foster said, well, pelvic floor therapy would work for pelvic floor. So I started sending patients to pelvic floor therapy because I didn't have anything else to give them.
Right.
And they started coming back, and it was amazing how much better they were doing. One of the things that he was doing at pelvic floor therapy was he would start off by placing them all on Metamucil, emptying them out, putting them on Metamucil as just a matter of course, because at Duke they noticed that urinary symptoms seemed to be related to defecatory symptoms. No one really knew why.
Okay.
But that was part of the mainstay of treatment was giving Metamucil. And then they would do different modalities of pelvic floor therapy. Well, these patients were coming back and they were basically cured. And I was amazed because it was 40% of patients that I could get better with typical endometriosis treatment that had endometriosis. Once the pelvic floor was getting treated, the pain was like gone. Like they were, and even their dysmenorrhea, which helped me realize that the cramping of the uterus. So the first patient that came back where it fixed the dysmenorrhea, I said, everything's better? What about your painful periods? And she said, no, that's better too. Didn't make sense. I don't know how the pelvic floor is going to affect painful period or is going to treat painful periods. But what I realized is I said, so you're not having any cramping? Oh, no, I'm having cramping. It's just not severe pain. So it was the cramping that was triggering the pelvic floor to spasm that was causing that severe pain. But that was getting better. Then I had patients that couldn't afford pelvic floor therapy. And so I would, or we were waiting on pelvic floor therapy to be approved. So I would go ahead and start them on the fiber, on the Metamucil.
Right.
We know they're going to do that, so we'll go ahead and, these patients started getting better just on the emptying out in the Metamucil. So I just started doing that. Let's just go ahead and empty out and do Metamucil. And then only a minority of patients needed pelvic floor therapy as long as they did that for 2 or 3 months. So that's how this all got pieced together.
That's fascinating.
Yep.
It's nice to have therapies that are effective, cheap, and safe.
Yeah, absolutely.
That's a beautiful thing in medicine. So so as we wrap this all up, Brett, tell me, what is pelvic floor therapy? Can you help us tell me what's involved? Let's say, okay, Mrs. Smith gets sent to pelvic floor therapy. What are they going to do there? I think most of the therapists are women.
Yeah, most of the therapists are going to be women. I think all of them that I know are.
They're going to be. I've never met a male physical. So you're going to go to a woman, so she's going to understand you're not going to be as embarrassed because you're with women. First of all, that's important. Yeah. Some women prefer female doctors. So the patient goes to the clinic. What are these therapists going to do? What are their various treatments, modalities, the things that they can do, please?
So the modalities. I'm not an expert in this, but from what I understand, there's something. So one modality is called electrogalvanic stimulation, and it sounds scary, but all it is like a TENS unit. So a TENS unit is something you can buy at Walmart, where you put a couple pads on a muscle,
and it shocks
the muscle, makes it contract, and it'll hold it contracted for a while, which fatigues the muscle, and then when it relaxes, it's relaxed. So there's something like this that it's a little plug that just goes in the vagina.
It's almost like a vaginal sonogram, but a little smaller.
But smaller, and it's a TENS unit, and it causes the pelvic floor muscles to contract and hold it there for 20 minutes, 30 minutes, and then it'll allow that to then fatigue the muscles. So that's one way that the muscles are forced to relax.
So there's an actual device, a TENS unit for the vagina that has this effect on the pelvic floor. Okay.
Another modality is what the physical therapists call manual therapy, myofascial release. So when the muscle stays contracted a long time, the covering of that muscle, the fascia, will wind up getting stuck.
Huh.
And so the therapist will go in and push in and pull apart and actually cause that to release by elongating the muscle.
Essentially a massage of the pelvic floor.
Massage of the pelvic floor.
I get one every week on my shoulders and my back. Pelvis doesn't have to be any different.
And then for particularly problematic pelvic floor, there are more invasive modalities. There's something called dry needling, or even small needles that go into the muscle that put an electrical signal that force it to contract so that it then relaxes.
Oh, boy, you have to be really good at placing it perfectly.
There are just a few physical therapists out there that I know of that are certified in doing that.
Sounds like it takes a lot of training and experience to do it right.
Mm-hmm. Yep.
So that's what a woman might expect going to pelvic floor therapy. And would that take frequently several weeks or several months?
I think so. Some of the regimens that I'm familiar with are either weekly or every other week. And the data that we have out of the UroGyn clinic that I am associated with is that it takes 2.5 months of every other week therapy to get an 80% improvement in symptoms.
Okay, so it's not an overnight usually. It's going to take a little time. But like any chronic condition, it took a while to get it. It's going to take a while to fix it. Fantastic. Well, Brett, this has been just a very insightful chat with you about painful intercourse and how to treat it. I've learned a lot of stuff, and I've been doing this for a little while. Are there any pearls or highlights or anything you would like to talk about, or anything I've not talked about yet as we wrap this up?
Yeah, I would say this. If you're out there and you think, wow, this is ringing a bell, like this, I'm having frequent urination, I'm having difficulty with bowel movements, I'm having pain with intercourse. The other thing I didn't mention is you can have pain with orgasm.
There's a clue.
Yeah, crampiness for 5 or 10 minutes, even with just masturbation or no penetration, because that muscle is tender. So when it contracts during orgasm, it can cause discomfort. So any of those are tells. So if you have those, I would say empty out, go get laxatives over the counter, empty out your colon completely, go on a soluble fiber, and I bet you'll find huge difference in everything affecting that aspect of your life within about 1 to 3 months.
1 to 3 months. Well, that's a great little pearl. Well, Brett, thank you so much. I'm going to put you on the spot right here. I understand you have lots of pearls and tips for women who are pregnant to have a successful pregnancy. Can you come back again sometime and we can delve into that a little further?
Sure, love to.
I also understand you are a beekeeper, and maybe sometime we can talk about the fascinating world of bees.
I am an amateur bee biologist. I would love to talk about it.
Fascinating. So we have a lot to talk about. So, Brett, thank you again for coming on the show. Thank you for your time today. I learned an awful lot. I hope my audience did too.
Okay, thank you.
Thank you so much.